Clear?
Yes.
Okay. Good afternoon, everybody. So, a quick talk about porcelain aorta tips and tricks. As introduction, definition, porcelain aorta is extensive classification of the ascending aorta or aortic arch that can be completely or near completely circumferential. You can find this among certain group of patients. However, it's not conclusive to them, like coronary artery disease, aortic stenosis patient, and the issue, the calcification of the aorta, it will complicate the surgery due to access entrance, risk of a stroke, and risk of aortic dissection. The most fearing two things is risk of stroke because it can carry high morbidity and mortality as well, and also because of the risk of aortic dissection. The atherosclerotic aorta is more prone to be dissected than normal aorta, as you all know. Liaital once analyzed about 1,861 patients, underwent CABG, and found among them 1.2% with porcelain aorta defined as a complete circumferential severe calcification. However, in the literature, you can find different incidence or prevalence of these. It can be range from 1 to 5%, depending on the specific group you are looking for. There is a multiple classification, for porcelain aorta, or let's say for atherosclerotic aorta. One of them is Miles and Verson. They classified atherosclerosis of the ascending aorta to 3 types, type 1, 2, and 3. Type 1 is complete circumferential medial calcification, which we all refer as a porcelain aorta. Type 2 is diffuse intimal thickening with rigid and friable edges as well. Type 3, intramural liquid debris as well. But each one of them carries a risk of devolving or leading to stroke. This is why even in all recent literature, minimizing handling of the aorta is currently recommended. Other calcification, and this is a recent paper, one paper mentioned that not all porcelain is the same porcelain aorta. It's depend on how much, in this paper, they propose a calcification of type 1A, 1B, and type 3. Type 1A, that is circumferential calcification of the ascending aorta with no possible clamping. This classification is more practical because either you can clamp, cross clamp, or you cannot cross clamp or find a place for arterial cannulation, cross clamping, all that. Type 1B, you have a calcification of the ascending aorta, but there is a possible clamping with increased risk, of course. Type 2, for them, it is the one we, a lot of us, they are seeing in our practice, that we have a descending and arch calcification as a part of atherosclerosis process. Other good paper about classification of ascending aorta, it's depend on the extent of atherosclerosis. So you have, they are dividing ascending aorta to 3 segments. Then the same segment, it will be divided into 4. The circle cross-sectional part will be divided into 4 quadrants. In figure 2, you can see the true porcelain aorta with the calcification all over from the aortic root up to the distal ascending aorta. For their classification, it's depending on the grade, which is grade 0 until grade 5, which is a porcelain aorta, and to have a more precise extent of calcification, they are dividing the segment into 4 quadrants as I mentioned. This is one of the review articles about the unclampable ascending aorta and coronary artery bypass surgery, and they mention all these, and they came up with a risk factor that age more than 70 diabetes, smoking, dyslipidemia, hypertension, patient with 3-vessel disease, diffuse or left main, any patient with peripheral vasculopathy, any patient with previous TIA and stroke, all that will lead to increased atherosclerosis as increased burden of atherosclerosis process. Other risk factor, of course, we have as when you want to diagnose or suspect this entity or increased atherosclerotic burden, you have to ask about diabetic, coronary artery disease, stroke, TIA, peripheral vascular disease, chronic kidney disease, radiation as well. Physical examination, you need to do head-to-toe examination, and PRUI, or you need to check for pulses. If any deficits in that, that will give you a suspicion of peripheral vascular disease, and that may promote you to do more investigation for those patients. Investigation, chest X-ray, echocath, CT. The most important things that pre-stenotomy diagnosis is essential for better planning and also for outcome. You don't want to be surprised in the OR after you open the sternum. This just to show you different modality. Here in the X-ray, you can see clearly a lot of calcification of the ascending aorta reaching the arch here in the cath, as well as you can see in the echo very clearly. CT scan is a perfect modality to diagnose this and to show the exact extent of calcification for all patients as well. So let's come to screening. Do we have to do CT scan for everybody or only for a high-risk group? What about epiaortic ultrasound? The most important thing that you need to keep in mind that careful history and physical examination and reading of all of your investigation that you order to determine and discover the porcelain aorta and who is in need for CT or further investigation according to your finding in physical examination and your standard investigation as well. Let's see what's in the guideline. The latest guideline recommend that regarding the CT scan of the ascending aorta should be considered in patient over 70 years of age and or sign of extensive generalized atherosclerosis. Before that, regarding procedural aspect, we have a class 1 recommendation for minimizing of the aortic manipulation. This is really recommended. And also prior to aortic manipulation, epiaortic ultrasound should be considered to identify atheromatous plaque and select the optimal surgical strategy. So for the CT and for this for high risk group, 2A recommendation, and for epiaortic ultrasound, it's given a class 2A as well. And class 1, you need to minimize your aortic manipulation to decrease the risk of stroke, which can lead to increased morbidity and mortality. This is just a summary about what I mentioned in the newest guideline, European guideline, actually this one. Many literature or many paper you can see regarding the efficacy of intraoperative epiaortic ultrasound, and that it can lead to change your strategy intra-op, and actually it's proven in many papers it will decrease the burden or the percentage of stroke for those patients. Does another paper also, does the routine use of aortic ultrasonography decrease the stroke rate in the coronary artery bypass? Actually, even in this paper showing that in patient with CAPAGE, just a simple modification after using of the epiaortic ultrasound lead to decrease the stroke rate in those specific cohort of patient. One paper was published in 2017 to specifically answer the question of does routine preoperative CT provide clinical utility in patient undergoing primary cardiac surgery. Many paper, I mean in the same paper, this table, you can see their best evidence paper. They are the one that they collected. For example, in this one, they have 1,754 patients taken from several different studies. They have a primary cardiac surgery, and 68% of them received CT cardiac outcome if there is any change in stroke rate or change in mortality. And key result was decrease in stroke rate of 77 to 96% in patients who had preoperative CT, and also decrease in mortality to 50% to 66% for patients who had a CT, with the stroke being the main cause of death. So as a comment of only this paper, no RCT were included in this meta-analysis. Findings were largely based on two comparative studies which use different imaging modality. Preoperative CT may lead to decrease stroke and mortality rates in primary cardiac surgery by allowing excellent visualization of the aortic calcification and improve preoperative planning. This paper and this and this and even the last one here, they all give the same idea and the same conclusion. You can read the full details of all those papers later. It's interesting actually. And the clinical bottom line for this, that the routine use of CT imaging, either non-contrast CT or CT angiography before primary cardiac surgery, provides added clinical utility by assisting in operative planning and potentially reduce the risk of stroke and mortality. Let's go quickly to the mechanism of porcelain aorta, or even increase the calcification. It is not exact same pathophysiological mechanism with atherosclerosis. Basic concept is aging, radiation, and chronic kidney disease may illustrate the following. One, aging, it can evoke paracrine osteogenic signal that are regulated by fibrofatty expansion via apoptotic vesicles arising from dead and dying vascular smooth muscle cell. This process can promote aortic calcium deposition, including specific changes in the vessel wall of a larger artery, including collagen and calcium deposition, and it will lead to loss of elastic fibers in the medial layers, causing stiffness of the arterial tree. Other proposed or important mechanism is intestinal radiation may cause aortitis, which generate calcium salt deposits as sequelae of scarred intima or media as well. Patients with the chronic kidney disease demonstrate not only accelerated atherosclerosis, but also diffuse calcification of the media of the large artery. Excessive media calcification is a result of osteoplastic transformation of a vascular smooth muscle cell, which can lead to formation of hydroxyapeptide in the milieu of excessive calcium and phosphate. So all it's about calcium and phosphates in the end. This is just to show you the schematic summary of what I just mentioned. So you have uremia, radiation, vascular inflammation, atherosclerosis. All that will affect the elastin, will affect the extracellular matrix vesicles and lead to inflammation, and also elastin degradation. And in the end, it will lead to more and more calcification. Risk factor as aging, hypertension, smoking, dyslipidemia, diabetic, chronic kidney disease, intestinal radiation, and systemic inflammatory disease with different disease, rheumatoid arthritis, SLAT, Takaso arthritis. All that can lead to increased calcification and lead to porcelain aorta at the end spectrum of the disease. So let's now move to arterial cannulation. Why I want to speak about arterial cannulation now, just to give you an idea, because after that, quick idea, because after that I will speak about specific patient with a lot of calcification of the ascending aorta, or let's say porcelain aorta with they need cabbage, or they need the aortic valve or mitral valve. This will be my next talk. So before that, we need the axis. So anatomic site for cannulation, for arterial cannulation, either you have distal ascending aorta, proximal aorta, innominate artery, distal arch, femoral, and external iliac or axillary and subclavian artery. Atherosclerosis of the ascending aorta can lead to dislodgement of debris, is a major cause of preoperative CVA and risk factor for dissection, as we mentioned. So all these decide that it can be used instead of ascending aorta if you have a lot of calcification in the distal ascending or in the base of the innominate artery. The most important thing that you need to all know if you have a faced or have a problem is hypothermic circulatory arrest, which is essential adjacent in aortic and pediatric surgery. Core temperature lowered can be lowered until 16, or let's say 18 to 20 using cardiopulmonary bypass if you have a deep hypothermic circulatory arrest. But as much as you go more and more lower, as the complication, especially coagulopathy, can it can happen post cardiac surgery. I mean more profound. Usually 30 to 40 minutes of interrupted deep hypothermic circulatory arrest at 18 to 20 is considered safe. When we use it if we want to repair distal ascending aorta or arch, or atherosclerotic disease or heavy calcification that would make clamping of the aorta is hazardous, and control and repair of massive hemorrhage as a result of cardiac or aortic laceration at reduced sternotomy. Other issue with the hypothermic circulatory arrest, neuroprotection, rate of rewarming, coagulopathy, antegrade, retrograde. We spoke about this before. So let's speak now about the porcelain aorta and coronary artery disease. Management option usually depends on multidisciplinary team approach, especially if this discovered pre-op. So either you can do off-pump cabbage versus BCI, or combined hybrid procedure. Sometimes you need to go ascending plus or minus arch replacement with cabbage and the circulatory arrest. Each of this option depends on patient situation, but it is very dramatic and extreme to go for ascending or plus or minus arch, especially if you only have cabbage. But the hybrid technique those days, you can just do off-pump lima to LAD, even if you are faced intra-op with this problem. You just, because it's anterior structure, the LAD in front of you, so you can do it off-pump and close the patient and refer him for stent for the other vessels after that as a hybrid technique. The visibility for total arterial revascularization with off-pump and no aortic no-touch technique, it's been mentioned in many paper and it's visible. Many paper also spoke about no-touch technique, especially in patients with familial hypercholesterolemia, because of burden of calcification with those patients, and also they will, because they are young and they will benefit more from total arterial, not more than the older people. Many videos you can watch about the techniques in many portal in the internet nowadays. This is one of them. I highly advise all of you to read this paper. about the art of arterial revascularization or total arterial revascularization patient with triple vessel disease. Multiple configuration can be done with those patients. The most important things that I want to emphasize when you want to do total arterial or you are using arterial revascularization, and this being mentioned in many literature and it's proven. For example, in the radial artery, you have to have a critical stenosis, which mean for the right side must be more than 90%. For the left side even, but in the left side in the literature, they mention 80 to 70%. And it's also been shown that REMA on the left side is more beneficial than the left side, but the exact mechanism why is that is still unknown. So even if you want to use bilateral memory, try to choose the best target on the left side. Multiple configuration, as I said, either in situ or in configuration with the radial artery. Here also, gastroepiploic artery not that much being used in some series and some sexes with those artery, but because of it's more prone to spasm, gastroepiploic artery one, than radial, than REMA, and also it's technically challenged, and there is also complication with the harvesting, with the bleeding, and all that. Sequential grafting can also be used. This is just to show you the technique of the sequential grafting. This a complete arterial revascularization based on 2 composite internal thoracic artery in patient with extensive aortic calcification. You can see he used a Aorta with a radial artery to feed the BDA. As I mentioned, this must be a critical stenosis of 90%. And in the left side also sequential graft Lima with radial artery as well. Now let's speak about atherosclerosis or porcelain aorta and aortic valve disease. Usually keep in mind that the innominate artery spare from calcification and can be good site for cannulation. Always the management plan depends on patient clinical scenario. High-risk patient, old with multiple comorbidity versus low-risk patient with familial hypercholesterolemia and porcelain aorta with coronary artery disease. Approach, it will be easy if it is only AVR. Nowadays, we can go with TAVI, but if you have to do like cabbage, AVR, mitral, so at that time you need to modify your technique. Either you go total arch with valve, ascending aorta with aortic arch, homograft. If you want homograft also, you can keep in your mind that you can do aortic valve replacement, ascending aorta with a homograft. Then you do cabbage, or you put your proximal graft on that homograft as well. Calcified homograft, decalcified, then AVR, or decalcified till it's bottom, then Bental, plus or minus suture, sutureless, I mean valve, plus or minus TAVI. All that is it can be used. Also sutureless valve, it's being used off-label with the patient with calcified or failed degenerative homograft. You all remember partner 1A, B, and 2, 3 trials with a high risk, inoperable, then intermediate risk, then the low risk. Redo, another paper speaking about redo aortic surgery for failure of an aortic homograft is a major technical challenge, but it can be done, but it will increase the risk of morbidity and mortality because of increased burden of atherosclerosis and increase the comorbidity with those type of patients. these just to show you, you can do peripheral cannulation, you can do axillary cannulation, either direct to the axillary artery or via graft. After you finish, you can sew the graft. This one show you for aortic dissection, of course, but just to elaborate about doing ascending aorta replacement or Bental, like in this case, this is just a small description about Bental. Here, continuation of the Bental, this one a capital procedure, usually with the patient with aneurysmal formation, and because of the aneurysm and push of the coronary button, you need to sew 8 millimeter tube graft to complete your button. Another paper, a comprehensive review about a porcelain aorta. What they mention in this paper, especially when they spoke about TAVI, that many patients technically were mentioned as an inoperable. They were having actually a porcelain aorta, and this was the reason of refer those patients to TAVI. Small scheme just to show you how TAVI is done. So if we have a mitral valve disease with porcelain aorta or unclampable aorta, so you can use alternative site for cannulation, as we mentioned before. Method for heart protection, either systemic hypothermia with fibrillatory arrest, deep hypothermic circulatory arrest, or endoclamp with retrograde cardioplegia, right thoracotomy. You can do MIS and do all that together. But if there is any rule for catheter-based management and MIS, yes, of course. This paper, myocardial protection during minimally invasive mitral valve surgery, strategies and cardioplegic solution. One of the special technique that if you are faced with patient that you cannot do cross-clamping of the aorta, so you can do beating or ventricular, either beating heart, both can be done, by the way, beating heart on pump, then you do your mitral valve, or under fibrillation as well. There is two techniques. So fibrillation is induced by cooling a patient 28 to 30, or by electrical stimulation, balloon catheter. And the most important thing that you need to use a vent, especially if you have a mild AR, and also if there is a previous mechanical aortic valve replacement. At the end of the procedure, ventilation resume once the left atrium has been completely de-aired. And if you want to do beating heart, you need to keep the patient on Trendelenburg position to prevent any air to go through, to prevent any air to go to the brain. So many paper about beating heart mitral valve replacement without aortic cross-clamping via right thoracotomy. It can be done. Another paper, efficacy and safety of beating heart mitral valve replacement. They did multiple series of patients and with their recommendation. Like nowadays also we have either mitral clip if you have MR, or if you want to do also mitral valve replacement via transcatheter approach, either transfemoral, which was only one device currently is available, and also transapical approach. This is transseptal approach. The same will be transapical approach. Initially, the TAMVR was balloon expandable, and it's only some series with the patient. They were used CPN valve with them, multiple, not great success. And also there is a several patients, they are really high risk patients with a limited treatment option, so they went to that option. However, recent paper just published in late 2019 about early experience with the transcatheter mitral valve replacement. It is a systemic review. And till now, they analyzed 308 patients were analyzed, and technical success rate was 91.7%. This is currently the device available for transcatheter mitral valve replacement. Maybe many of you will ask why in the cabbage, in the AVR or the TAVI, we have a great success with the TAVI valve, not like in the mitral. The problem is actually many problems, the anatomical or the challenging in the anatomy. In the the challenging in the anatomy of the mitral valve. Two, the size of the mitral valve, which is big. And that will lead us to the third point, which is if you want to do transcatheter because of the big valve, so you need a big sheet. So this is why I can show you here, maybe all the device you can see here, approach and delivery system, because you need a big valve. So in the big valve need big delivery system. It's all transapical, just apart like Livinova, they design transfemoral or transseptal, and also the transfemoral also, yani cardio valve also. They have a transfemoral, and CBN, of course, they have transfemoral. They are developing, but all that will affect the delivery system because it is a big valve and need a big delivery sheet. This is why many of them via transapical, and also the complex anatomy of the mitral valve as well. One of the most important ever is trial, percutaneous repair or surgery, then you have QAP trial, all that. But that's for mitral stenosis, and it shows good benefit for high-risk patients, especially with the QAP trial and the recent trial coming more and more. The mitral clip is for mitral regurg patients, and only for patients deemed very high risk for surgical intervention. So as a summary, porcelain aorta or calcification is an uncommon entity, uncommon as a porcelain aorta, but calcification, it is quite common, but it's associated with a high morbidity and mortality because of the stroke and dissection. Preoperative recognition of porcelain aorta is essential to plan the optimal approach and to improve clinical outcome. And the most multidisciplinary approach is of a great importance and value with those subset of patients, because it will improve the outcome, decrease morbidity and mortality. So all the tools that you can use from the beginning of your interviewing your patient history, physical examination, reading your investigation, ordering the necessary investigation that need to be ordered, all that is very important. Thank you very much. Please, if you have any question, please, you can ask me. Unless you are all asleep, I don't know.
إذا ما حد عنده سؤال أسألك أنا.
تفضل دكتور.
طيب, what's the incidence of porcelain aorta?
It's been mentioned that it is 5% in many literature. However, I read one paper, I mentioned it before, that they mentioned that the true incidence is maybe 0.2%, because the true porcelain aorta is a complete circumventional calcification, which is really a rare entity.
So many people say it's around 1.5%. Let's say in your practice, a patient, how old is what's the average age for those patients, by the way?
Literature mention more than 70 years. However, the age will be influenced or decreased depend on the other risk factor as well. But by age per se, 70 years, what I read. Yeah.
Okay, 70 years is a risk factor for unclampable aorta. But the many cases that I have seen personally with porcine aorta were very young patients, 40, 50 years. For some reason, they have a different pathology. Maybe the main pathology is not just atherosclerosis, but inflammation. Anyway, let's ask you this question in a different way. You have a 75-year-old man coming for CABG. Do you do routine CT?
Myself, yeah, I prefer if it is 70, if he is 75-year-old.
But this means يعني the majority of your patients حيكونوا يعني حيجيك في السنة 1000 مريض 100 مريض, let's say. You're going to have 100 patients. Only 1 or 2 will have porcine aorta, and you'll be doing 50, 60 CT ولا كده.
But يعني 75-year-old usually it is a risk factor.
It is. But in your in the practice that you are seeing right now,
Yeah.
do you see that done routinely for
Yes.
patients above the age of 70?
Yes, if they are above age of 70, yes. But if it is above age 60, 65, not all of them, we discuss them. And according to the X-ray, according to when we see the CAT, some of them will do for them CT or the other risk factors, some of them no. But not all.
What are the major risk factors you look for to prompt to do CT?
Patient with a chronic kidney disease, one. Patient have any prior history of radiation or any prior history of any oncological disease like lymphoma, even without radiation. Patient with peripheral artery disease or any patient left main or patients with carotid disease. We will do a CD, if they have collective of all those risk factors, we'll do CT even if they are 60-year-old or even 55.
So you need to know more about carotid disease and how do you discover it preoperatively in the physical exam. What are the things they do and when do you do ultrasound for the carotid? Let's go back to this patient. On the chest X-ray shows calcification, and you do a CT scan. He has porcine aorta. What do you do for those patients? Do you proceed with surgery? He needs CABG.
How old is he?
75.
75. I will discuss with the interventional cardiologist if the stent can be done.
Not good vessels for PCI.
Not good vessels for PCI, and he needed with a good functional class. So I will sit with the patient, explain to him all the risk and benefit of the surgery. But
what's the risk? What's the risk of a stroke on this case? He's asking you.
The risk of stroke. As a percentage, because I'm planning to do off pump actually with no touch technique, but still the risk is there. But
how bad risk, doctor?
I'm not sure. I don't know the percentage. I don't know. I know it's high.
But people will ask you, and especially patients will ask you, what's my risk of going through the surgery? You should know at least the normal risk. What's the normal risk for CABG?
2 to 3%. Is again the age.
Okay, and this will be higher, lower?
No, this will be higher.
Much higher? Okay, so you need to know that number. Now, let's say the patient did not have anything on the X-ray, no calcifications, and he's 60 years old. You take him for CABG. Do you do, in your current practice, what you see in your life, do you do epi-aortic ultrasound?
Actually, yes.
You do, huh? طيب والله ما شاء الله ممتاز. Okay, because I can tell you 90% or 95% of the surgeons do not do it.
Not all the patients. Actually, I'm depending on the TEA. But if there is a lot of calcification on the TEA, so I will ask for the probe يعني intra-op, then I will screen the aorta by epiaortic ultrasound. It happened with me multiple times. Then I call the consultant that saying, boss, we have 1, 2, 3, and it happened with me. But
Do
not
you do TE for cabbages?
Yes, in our hospital, we have TE probe in all patients. So even when I did a rotation outside our center in Riyadh, they also do TE for all patients. So before I'm doing cannulation stitch, I'm asking the anesthesiologist, and I ask him, please check for me the aorta, and I'm looking with him. This is my personal routine, what I do.
Okay, they always comment that the TE is not good for visualizing the anything above the aortic valve. The ascending, the arch is very difficult to visualize with the TE. Anyway, but it's recommended that you should do epicardiac, epiaortic ultrasound for all cabbage patients, though routinely many people do not do it.
Yes.
Okay. بغيت أسألك حاجة تانية على المحاضرة اللي قبلها. If you have a patient with severe constrictive pericarditis and it's about 1 centimeter all around the heart, what are the technical pitfalls? What are the technical things that you do when you go on after opening the sternum? How do you do the pericardiectomy? Have you seen one?
Yes.
طيب قول لي كيف تسويها.
So you start, the most important thing is to find a suitable plane that you start with, one. After you found a suitable plane,
يعني you open the whole thing and it's just like a big خلينا نقول chunk of stone of calcium. ايش تسوي؟ كيف بدأتوا الحالة حقتكم هذه؟ فين بدأتوا؟
From the diaphragmatic surface. Okay, if you have all like this, the best area you can start from is like in the redo. You can start from the diaphragmatic surface, and after that you go up.
The diaphragmatic surface for redos. Why?
Why we start from there?
Yes.
I'm not sure why we start from there, but what I know, it is free of a lot of adhesion and also
that's the main reason. That's the main reason. It has the least adhesions in that area for some reason. Okay, go back again to this patient who had full of calcification, almost like a stone. We usually like to start, and that's the pitfall. I'd like you to hear this, and maybe your colleagues as well. We should start somewhere on the left side, not on the right side. You should start on the left side and should try to work on the left side of the heart as much as possible, and then behind the heart until you free most of the, or quite a bit of the left ventricle before you start working on the right ventricle.
Yeah, because you don't want to have what they call it, acute pulmonary edema if you release the right side first.
بس هذه النقطة. This is why I wanted you to يعني to realize or remember. كيف بدأتوا أنتوا الحالة اللي سويتوها؟ كيف سويتوها؟ أول شيء عاش المريض ولا ما عاش؟
لا عاش، كل اللي أنا شفتهم عاشوا وخرجوا من المستشفى.
والله ما شاء الله، يعني ما أبغى أقول لك constrictive pericarditis كانوا ولا كانوا أي كلام. لأنه على أيامنا كانوا يعني we had it's a major procedure, by the way. It's a very difficult procedure. It takes hours and hours. If you're meticulous, يعني it can take easily 6 to 8 hours in the OR.
Yes.
Okay, and I'm talking operating قبل بعد الأنستيزيا وقبل التكفيل وكذا. فيعني it's a very tough surgery, and it can, if you injure anything, يعني it can be a major disaster.
Yes.
And it's not an easy procedure. يلا الله يعينكم. We did have يعني I did my share of it, and I did have some mortality, but yes, most of the patients survive. يعني maybe 70-80% of them will survive. طيب ما ادري كان احد من الشباب، انا اخذت عليك الجو، ما ادري كان احد من الشباب عنده اسئله.
لا يتفضل. mortality, and it's been mentioned in the literature for pericardectomy 20 to 30%. It's really high, as you said, boss. يا شباب شكله مستنيين الفطور ولا ايش؟ ما حد داري.
We are enjoying the discussion.
هلا؟
We are only enjoying the discussion.
طيب اتفضلوا، اي سؤال اي حاجه، يعني الواحد حتى لو ما يعرف يروح يدور يعني.
مين الكونسلتنت معاكم اليوم؟
اليوم معنا البيج بوس يا بوس.
ما شاء الله عليك. الله يستر. طيب اقول لك، شوف اليوم في الصباح كان الدكتور فيصل شمدين رتب محاضره في تخصصي. It was about aortic valve surgery. They are now very active في الكينج فيصل. They are taking all the consultants، وكل الكونسلتنت متحمسين ويسووا محاضرات وبيكلموا فيصل وبيسووا معاه جدول وكذا. بعض المحاضرات حتكون في الليل، بعض المحاضرات حتكون في النهار، على حسب ما يعني اتفاق بينهم. فإذا تحبوا نسقوا مع فيصل خليه يعزمكم على بعض المحاضرات الحلوة هذه.
طيب خليه بس يكلمنا، انه احنا شو اسمه